apagamos, sí. Que arriba se han ido. Bueno, buenos días a todos y gracias por estar aquí, a los compañeros también de otros servicios. Tenemos aquí como invitado hoy, es mi placer presentar al doctor Ferko Berger. Hemos estado en un congreso ahora hace nada de radiología de urgencias y bueno, está unos días por aquí y ha sido tan amable de querer venir y darnos una charla, y elegimos este tema porque también estamos, preparamos nosotros un protocolo, ¿no? Multidisciplinar con cuidados intensivos, cirugía, traumatología y creíamos, y por supuesto urgencias, y creíamos que era interesante, ¿no?, este tema. Entonces Ferko os lo voy a presentar. Yo tengo aquí mis notas. Él es profesor asociado de la Universidad de Toronto, es el jefe de la División de Radiología de Urgencias y Trauma en el Departamento de Imagen Médica del Hospital Universitario Sunnybrook en Toronto y es investigador asociado del Instituto de Investigación de este hospital. Actualmente es vicepresidente segundo de la Sociedad Americana de Radiología de Urgencias y es miembro de la Junta Directiva de la Sociedad Europea de Radiología de Urgencias, de la que yo soy ahora mismo presidente electo, y es miembro también de la Sociedad Canadiense de Emergencia y Trauma, de Radiología de Emergencia y Trauma. Es súper apasionado de la radiología de urgencias, ¿no?, a lo que se dedica él. Y deciros que su hospital, el Sunnybrook University Hospital de Toronto, es un hospital de 1.325 camas, es un gran hospital, 700 de ellas dedicadas al tratamiento de pacientes agudos, con 128 camas de urgencia solo para pacientes agudos. O sea que es un gran hospital de trauma, es un Level 1 Trauma Center que llaman en Norteamérica. Y es el mayor y más antiguo hospital de trauma de nivel 1 de urgencias neurológicas y cardiovasculares y el sexto en oncología en América del Norte. Bueno, o sea que él es el jefe de una sección de este hospital, ¿no?, de trauma muy importante y tiene muchísima experiencia con muchísimos casos. Y pues nos va a hablar del TAC en trauma, Always Whole Body CT, siempre debemos usar esto. Pues adelante, Ferko, cuando quieras, un placer tenerte aquí.
¿Mejor? Sí, eso es. I hope you understood a bit of what I tried to say in Spanish, but be careful, I do understand some. So it's my pleasure to be here and to be hosted like royalty by Ana in the days I've been here. And I recognize some faces from Valencia, so thanks for being here. So yeah, I'll try to discuss this topic this morning on whether to do CT or not in trauma, whole body CT. And that's another reason to do it in English, because it's not an easy topic, which you will understand from the rest of the presentation. So my first disclosure is that you may leave with more questions than answers. I hope I will provide you with some utility of the talk, but maybe it's better to judge by questions than by the answers for this talk. A little bit about myself. I'm originally from the Netherlands, from Amsterdam, and this is unfortunately a picture from decades ago, because there's not that much ice anymore in the canals in Amsterdam, but in Toronto we skate in a bit more modern environment, so that's where I went in 2016 to be at the Level 1 Trauma Center in Sunnybrook. And you already explained it's a massive hospital, and I don't think I would have changed my academic career in Amsterdam for Toronto, for another hospital or anywhere else in Canada. So I'm talking from my experience that I have, which is mostly the Netherlands and Canada. And as you can see in this picture, I thought everything would be better in North America, but the patients, this is their entrance to the emergency department in winter. And I now understand why Canadians walk with shorts in any type of weather that I would need a big parka for. So, but I'm putting this here also because I find it very important to state that I was not brought up in the Spanish system or in any other system, and whether you do whole body CT or not is very dependent on your own setting. So I'm not trying to profess how you should do it. I'm just trying to say or explain some of the literature behind whole body CT. I will try to go over some of the protocols in CT that you could use. The question about who needs a whole body CT, and then if you don't do whole body CT, how can you safely exclude patients from getting a whole body CT and do a selective approach? Since I haven't met most of you, only Anna, I guess, and some in Valencia, I want to get to know you first. So who in the audience is not a radiologist? If you can raise your hands. Okay, great. Trauma is a multidisciplinary effort, so it's good to have some people that come from other parts of the team. And here in your center or where you work, do you always do whole body CT in patients that are polytrauma patients as we think to see it from the patient? Mostly? Yeah, okay. And then another question is there always a radiologist or a trainee in the trauma team at the resuscitation bay and at the scanner? I see some nodding of heads. So yeah, that is very nice. In Amsterdam, we were the ones doing the fast in the trauma bay, and because the reporting room was so close to the trauma bay, we would usually be there first, and the paramedics would start to give the handover to us, which is not necessarily the best probably, but in Toronto we're so busy that we unfortunately cannot be in the trauma bay. We need to report all the CT, so something I miss, but good to know that you are very involved here. So in the rest of the talk, I will touch on some basics for the assessment of whether to do whole body CT or not. And then I go over some of the meta-analyses that exist in the literature. They're a bit older, but still useful to look at them. Then the REACT-2 trial, which is the only prospective trial so far with the highest grade of evidence for whole body CT. Then, as I already introduced, we will have more questions that we'll try to show. And then a few more recent publications, as well as the trauma guideline in North America that was made with people from the American Society of Emergency Radiology included in it. And then try to give you something to take to work. I hope you don't take it home. I want to also say that this presentation deals with adults and with blunt trauma, so this is not for penetrating trauma. Sunnybrook doesn't take care of children, and so we don't see those. And most of the guidelines and other things are built for adults as well, most of the studies too. And then whole body CT, what do we mean with that? It's a CT of the head, neck, chest, abdomen, and pelvis at minimum. You can, of course, do the extremities in addition as well, but this is the minimum. So I'll touch on the basics first, and this is what we don't always realize anymore, but this is what happens on scene and where our colleague paramedics need to do their work before we see the patient in the hospital. So trauma still accounts for about 10% of all deaths in the Western world, and the leading cause under the age of 45. And there's a lot of residual disability, so we often talk about the mortality, but not the morbidity as much. But it's a major cost to not only the individual, both financially and health-wise, but also to society. To improve that outcome in patients, we all know that we need to act quickly and accurately, and that's where the definition of the golden hour arose, right? It's not really an hour, it's just the urgency of the mindset that you need to have when you deal with trauma care. So to treat timely and accurately, the ATLS was constructed to go in a very systematic approach by the patient. And that's a clinical assessment, but it leads to both under triage and over triage. So some patients are doing much better when you see them than they actually are, and some seem to be much worse than they may be if you do all the assessment with imaging. So there are some imaging guidelines in the ATLS, and this has evolved. We're now in edition 10, I believe. The current guidelines for imaging are still to do radiographs and EFAS, and this is in part because ATLS is also done in countries where there is no CT, right? So this needs to be bulletproof sort of to the rest of the world as well. But radiographs extended fast if you can include the chest, and selective CT. That was what was in the ATLS, but I think from our own practice, and I hope the images will show okay, there's a lack of sensitivity of the chest radiographs, for example, because if you look at the mediastinum here, it's normal, but if you do the CT, you actually see the traumatic injury to the aorta as well as the hyperextension injuries to the spine, which you would not have picked up on the radiograph. So that's why CT has become so important. The same with ultrasound. So the EFAS, we all know it's a tool that we use to look at fluid and maybe pneumothorax, but fluid in spaces where it shouldn't be. And this is why. This is a liver. You may think there's something happening, which is correct if you, oh sorry, it was a spleen, if you look at the CT. And the same with the kidney. If you do a CT, you pick up the solid organ injuries to a much greater extent than with ultrasound. So ultrasound is good too, and this is, by the way, a courtesy of Digna Kool, who also was in Valencia, but my mentor in trauma radiology from Amsterdam. So we became more and more aware of the lack of sensitivity and also specificity of conventional radiography and ultrasound. And in parallel to that, CT scanners moved from far away in the main department much closer to the emergency ward, or maybe even in the trauma room. CT evolved with much faster acquisition and reconstruction times and a much longer scan range, so now you can easily scan 2 meters, and became much more accurate with the modern scanners. So this led to, all these factors led to doing much more liberal whole body CT. And now, in fact, 60% of trauma centers in Europe have facilities like that where you can actually very quickly assess patients. That all seems very nice, but of course, the world is not always perfect, and CT is neither. So in the perfect world, there would not be any negative effects of CT, and there would be no discussion. But I'm talking here about whole body CT because that's not the ideal world we live in. So yes, there are a lot of positives, It's more accurate. The time to diagnose and the time to treat are less with CT. There's a reduced length of stay in the ED and reduced mortality and morbidity. There's some debate at times about that. But we also need time for the procedure, and we take patients sometimes away from the environment where they're safe. We give radiation. There's cost involved to CT. And there's a lot of incidental findings in these trauma scans that also have a negative or can have a negative impact on the patient. So that's sort of painting the landscape, and then I wanted to go into some of the evidence of whole body CT, and I want to highlight a few things that are maybe not necessarily intuitively apparent when you look at the literature, when you start reading about this, when you want to make up your own mind about whether to do whole body CT or not. So what sometimes appears to be the solution actually gives more questions, and that's because there's many factors that contribute to the heterogeneity of all these studies. So it's not all that easy to come to a conclusion. And the most important thing in all these papers is that the practice is extremely variable, and I will highlight all the things that vary between these studies. So it's difficult to define an answer definitively. The practice variation has actually been studied very well in Europe, in the Scandinavian countries, Switzerland, and the UK. And these are, and I happily share these slides, so you don't have to memorize all the articles that will pass. But so this is just 3 examples on practice variation. And the very first thing that varies between all these studies is how they select their patients to evaluate whether whole body CT is good or not. So the Swiss defined a patient for their inclusion as a patient that has more than or 2 or more severe injuries, and even the definition of severe varies between these. And then in the survey of the Nordic people, the variation is a lot more even. As you can see in this slide, the mechanism of injury, for example, is the most common contributor to whether to select a patient for whole body CT or not. But it's the other thing, like abnormal vital signs or they decrease in how much they use it as an inclusion criteria to do a whole body CT when they study this. And then in the UK, it was actually unclear what were the selection criteria for whether to do a whole body CT or not. And then going a bit more in depth into the world of us as radiologists, what were the CT protocols that they did to do these whole body CTs? So here you can see what the Swiss found, and what I find interesting is that only 80% of centers did an unenhanced CT brain. In my teaching and what I do in practice is you always, if you need to image the head, you always do an unenhanced CT of the head, because after contrast it can be more tricky to find small bleeds. And if you look at the Nordic survey, again, the way people address trauma patients is not uniform at all. So that's one of the reasons why literature is difficult to interpret. In the UK study, CT protocols were not even documented, so it's impossible to know how the UK sites did it. But what they did notice is that in a center that has a major trauma designation, there's 5 times more whole body CT being done than in the community or lesser trauma designation hospitals. So just to go into what the variability is, just for the topic of CT protocols, I've given 4 scouts here. And one of the things that is important in the literature is the radiation dose, right? When we need to decide whether we do whole body CT or not, an important component is the radiation we give to the patient. So this is how you would do a CT with a split bolus protocol, and you do an unenhanced CT head and neck, and then a split bolus of the torso. This is doing an enhanced CT of the head and face, and then a split bolus CTA of the and portal venous phase of the neck and the torso. And this goes on, and the more phases and body regions you scan multiple times, of course, the more extra radiation you give to the patient. So when this is important in these literature studies where they compare the radiation dose as one of the arguments of whether to do whole body CT or not. But then there's, do you add a delayed phase routinely? So in North America, where the radiologist is not necessarily always at the scanner, many centers include a delayed phase routinely. They don't even go and see the image and decide whether or not they should do that. The scanner type, old scanners versus new scanners, timing, iterative reconstruction, yes or no, many of these other reasons, and now dual energy CT or not. These are all factors that are important to radiation dose. And then the position of the arms, and I'll borrow a slide from my good friend Mark Bernstein, who has made these illustrations of the human body as they can be put into the CT scanner. And this is what is known about the radiation between them. So if we take the one with the arms up as the base line, then having the arms next to the body is about 45% higher radiation dose. One arm up, one arm down is about 18% higher radiation dose. And arms across the body but lifted with a pillow to minimize the streak artifacts is about 25% higher dose. I'm not professing how you should do it. Again, this is just to illustrate that there is a difference in how you do it as to how much radiation you give. There's of course impact of where the arms are to the neck imaging, and as well to the imaging of your liver and spleen when they're close to your torso. So this protocol variability will not only define the radiation dose, but it will, because of those artifacts, also influence the detection rate of injuries, and especially vascular injuries. It will impact the number of reconstructions that you as a radiologist have to deal with, or as a team taking care of the patient. And it will impact the time of acquisition if you need to move the arms between the phases, or if you do an unenhanced CT of the neck to then judge whether or not you need to do a CTA. That all impacts the time spent at the scanner. And these are all hidden inputs into these studies that look at whole body trauma CT. So patient selection, imaging, algorithm, CT protocol, patient management, there's many things that in this literature are not necessarily very clear. So you can probably defend anything you as an institution would want to choose. So let's look at some of these meta-analyses. And these are, as I said, a bit older. They're from the early 2010s. And they looked at whether whole body CT is useful in doing liberally in trauma patients or not. And there's a few more, and I will highlight them in a table after to group them. So here it is. And this is very synoptically the conclusion of these meta-analyses. And you can see the older ones said no, and the newer ones said yes, you should do it because there is a mortality advantage of doing whole body CT. It's good to know, though, that all these studies only got to second or third grade of reliability of a meta-analysis. And a meta-analysis is our highest level of evidence, right? So you would like to have a lot of randomized studies which are then put into a meta-analysis, and then that would hopefully get a grade 1 for the evidence of doing whole body CT. But none of these studies even come close to that, these meta-analyses. This is just an excerpt of one of those meta-analyses, and there are some positives in those studies, but The other 9 studies only got a maximum of 2 of, I believe it was 5 stars, and some other things as well. So our understanding or our foundation to argue about this is flawed. Here again, this is a table. I hope it comes across. You don't need to read all this, but I want to highlight again, the evidence is not very strong. So it's important for us as physicians to use our intelligence as well to see what we think from our experience. Again, this is another paper sort of highlighting the same. Another problem is that in these meta-analyses, the studies by Huber-Wagner are quite large and often both named, but in the study that has almost 17,000 patients, these 4,500 patients are included again, so they count double in these meta-analyses as well. They're not independent studies. This is some more, I'm not gonna, this is the same. I'm showing those 2 studies, but in these meta-analyses, there's a few outliers that have a lot of patients, and there's some issues with these studies as well. So let's look at these that say, yes, there is a proven mortality benefit. The latest data included in any of these studies, and they show a big number of patients, right, in the 20 and 30,000s. The latest data included is from around 2013. In my hospital, the scanners have gone far beyond what we did in patients in 2013. So that is one caveat to this. But again, the largest single study in these meta-analyses already takes more than half of the patients of the analysis, as I alluded to before. And of course, they're all retrospective, and they're very importantly based on trauma scores to calculate the expected mortality. So when they want to prove that whole body CT is useful to reduce mortality, what they do is they calculate the mortality that was expected and then compare it to the mortality that was actually found in these studies. And I will explain why that is important. So in all these studies, these scores are used. It's either the TRIS score is used or the risk score is used. And those are used to assess the severity of the patient. These are calculated differently in all these studies, but there's one common issue in all of these, and that's that they use the injury severity score as part of the score to calculate the expected mortality. There is, however, an issue with the injury severity score, and that in whole body CT, you inflate the injury severity score, and I'll explain that. But for those who are unaware of the injury severity score, is you calculate it by assessing an injury grade from 1 to 6, with 6 not being survivable. 0 is normal, so that is not calculated. And then you do that for these regions. And then in the end, you do a square of all the individual, the 3 most severely injured regions, and you can have a maximum score of 75, and basically you don't survive. So let's look at the same patient that has gone through the selective approach or the whole body CT approach. When we do more CT, in most patients we will find more findings. These findings are taken into account for the ISS of the patient. So if we would not have scanned the chest, for example, but we see a few rib fractures, the score, the injury severity of the patient will go up, but we don't know if it would have been clinically important, because if we would not have scanned that patient's chest, it may not have ever come to light. So if the regional injury severity score increases because you now start to image, then the ISS will even increase squared, right? If you wouldn't have found anything, it would have been 0. If you then have a minor injury, say 2 for that body region, you add 4 points to the ISS, which means that calculating the expected mortality is going to increase because the ISS is higher. And if you then compare it in your studies with whole body CT, then of course it's beneficial, because if you would have done selective CT, you would never have found that injury, potentially. So in a study by Gupta, they looked at that, and they found that 13% of the population had a doubling of their ISS purely by scanning the whole body, irrespective of the outcome. So this is what I already tried to explain. If you do this, then you artificially inflate. So you will therefore deduce that whole body CT is better, because you've picked up more injuries, even if they weren't necessarily all that important. The other thing with the ISS, it does correlate with mortality and morbidity and some other factors in patient care. And they are used to define major trauma, which is an ISS over 15. And this is actually from trauma.org, one of the major trauma reference sites. They acknowledge that that there's an issue, but the biggest one is that it is a retrospective calculation. So this is very useful for trauma registries, but not when your patient is in the trauma bay. You're not calculating ISS, right? So it's not useful as a triage tool. Well, and then looking at these studies more, what I'm trying to do is to show you that it's not easy to interpret this literature because of many biases that exist, and I've already touched on these. So to recap, the evidence in these meta-analyses, or in general, is not great, and the largest study and more studies actually skew the results because of using the expected mortality. So the conclusion from all these meta-analyses is that whole body may be associated with decreased mortality, but the causality between those things cannot be concluded definitively. And most of these studies will actually be honest about that, and they say, we need a randomized controlled trial, but that's very difficult to do in trauma care, of course, to say, okay, let's see the same patient, this patient go to selective and this go to whole body CT. But there's one study that actually was starting at the time that they refer to, and that's the REACT-2 trial. So that is exactly what they tried to do. So I'll go into the REACT-2 trial. It's been concluded since, and it's been published. What's very important in this publication, because I have actually not highlighted that, but the REACT-2 trial differentiates selective CT versus immediate whole body CT. So when you do the whole body CT is another factor that differs between these studies. And it's important, because if you do the whole body CT 2 hours later, it may be different than doing it when the patient arrives on the CT scanner. So in Amsterdam, one of the centers, the center where I trained, they actually have the CT as the resuscitation table, so they can do CT in very heavily injured patients. What they did was they included, or they prospectively assessed and randomized 5,500 patients, and some got immediate whole body CT, and the others got the normal routine workup with the EFAST radiographs and the selective CT. They had to be over 18 years, and one of the others, so compromised vital signs, or suspicion of life-threatening injury, or a significant injury mechanism, and this was all to the discretion of the team. So this is, there were quite a bit of exclusions, but this is how they the number of patients they included. So fairly even distribution. The only thing is there's crossover from mostly the selective routine CT to the whole body CT category. So they basically, even in the selective cohort, did a lot of, or not a lot, but a fair amount of whole body CT in the end. Other factors are pretty similar between the groups. Oh, sorry. And what they found was that there was not a statistically significant difference in mortality in the first 24 hours in the hospital, or in the injury severity of the patients and in the traumatic brain injury, nor in mortality after 30 days. So to them, it didn't really make a difference. There was, however, a logistical difference. So here you can see all the p-values that are statistically significant. One is borderline, that's time in the ED. But the whole body CT approach did have less radiation dose, especially if you calculate everything happening after the whole body CT in the hospital. The time of imaging was reduced, the time to diagnosis was reduced, and the time in the ED was trending to be less compared to selective CT, but it was not statistically significant. But also this study had limitations. So 36% of their population turned out not to be severely injured patients, not polytrauma patients. And as I said, a sizable amount of the patients that got selective CT actually turned out in the end to have a whole body CT. There are some further issues. The subjective inclusion criteria of, and that's our experience again, but if you receive the patient, you have to make a decision whether or not to do the whole body protocol or the selective protocol, even in this study. But they did address those numbers, and they are the first to be completely transparent about this. As for radiation, there were quite a few that had a low injury severity score and may not need whole body CT. But of the, and I said it before actually, of the patients who got the selective approach, there still was the dose of a whole body CT. And I've mentioned these already, but their conclusion is that they are the first level 1 evidence study, prospective randomized control trial. But even their conclusion is disappointing, right? Improvement of selection of patients who benefit from immediate total body CT should be the subject of future research. So where all the meta-analyses were saying, oh, but the REACT-2 trial protocol is published and they will soon do it, they will come with the answer. But they didn't, so now what? There were questions around clear indications. I was actually expecting another slide, but that doesn't matter. In other reviews, they try to address some of these questions as well, but the conclusions are sort of similar. They all say there's a wide variability between centers, and it's hard to come to a consensus on whether to do whole body CT or not. So this is where I made a note to myself: stop expecting to find your answers in literature. And I found this sign: welcome to the city of disappointment, and don't stay too long. So we'll move on and try to get you some answers at least. So let's look at some further questions, but before we do, I want to show some cases, because, I mean, we are radiologists in the end, but it's maybe not projecting the best, but you have to trust me, this is radiographs in addition to a negative extended fast that are normal, but the whole body CT did reveal multiple injuries that were not picked up on the initial trauma bay assessment. again, debatable how much this would change patient management or outcome. This is something very typical to Canada. This I don't see in the Netherlands because we don't have snow and we don't have snowmobiles, but it's quite impressive to see how many accidents happen in Canada. The other thing is in Canada, the trauma season, as we call it, is the summer, whereas in the Netherlands, it's the winter when the roads are slippery, but so there's all these local differences. This is another patient, fairly normal, but had some subarachnoid hemorrhage, and of course the incidental lung nodule that needed follow-up according to Fleischner criteria. And then yet another one with minor injuries, as you may think, so some skeletal, an ankle fracture, and actually bilateral knee fractures. I zoom in here. I don't know if it's very well visible, but there was a whole body CT with the extremities, and in this case it was actually not helpful. There were no further injuries than the injuries to the skeletal structures. And then this, I think, even with the bad projection, you would immediately say that this is quite abnormal. And as I like to teach, I don't speak about a widened mediastinum. Please get it out of your language. The contours in the mediastinum are abnormal. The width of the mediastinum on its own is completely unreliable. So in emergency radiology world, we try to eradicate the widened mediastinum. But that still doesn't show the acuity of a case like this, because you can see that it's not a contained traumatic injury of the aorta. It's actually a patient that's bleeding acutely from the aortic injury. So even if you do have positive significant findings on the radiographs, you may still need the CT for decisions about management. So the further questions that you can ask, rather than should we do whole body CT or not, and the answer is not all that clear, is when can we not do CT of the chest or abdomen and pelvis? Or when is it safe to do the selective approach? And when do we definitely need to do immediate whole body CT? The answers to these questions depend a little bit on your own comfort level. Do you want to find every single small injury, or do you only want to find the major injuries that are clinically relevant, even though the term clinically relevant is, again, variable in literature? So back in 2010, there was a study, a prospective study about doing chest and torso CTs in patients under the age of 55 with no suspicion of physical, laboratory, or conventional imaging findings. And they found that if those all were true, then clinically significant findings in their definition only happened in 2% of the cases in the chest and less than 0.5% of the cases in the abdomen and pelvis. Another study showed in a retrospective cohort of 523 patients, they stratified the risk of the patients in 3 categories, and you can see that the number of whole body CTs they did in these patients decreased by the level of injury, and actually they didn't find anything on the whole body CTs that they did do on the patients with a very low risk of severe injury. And these are the definitions that they use, because again, it's important to know what the definitions were in the literature that you read. So high, they defined as vitals, compromised, or specific predefined injury types of mechanism of injury. Intermediate risk was normal vitals, but at least one region with an AIS of 2 or more. Again, this is a retrospective study. Or if the patient was intoxicated. A low risk is if the vitals were normal and there's no other major suspicion. In their follow-up of 36 months, they didn't find any additional injuries, but they did conclude that whole body CT is too much radiation. So when to not do CT, according to some of these studies, is if it is a very low-risk patient, they are mentally alert, not intoxicated, and there's only signs of minimal injuries in your assessment of the patient in the trauma bay. And then you can do re-examination, but not whole body CT. And I think we all know the patient that comes in like that, and if you look at the neck collar, then you already know that this patient is probably fitting into the category of the lesser injured patient. There's a few other studies that have actually tried to, I think most of you will probably know the nexus criteria for the C-spine or the Canadian C-spine rules. So there is actually a group that has tried to come up with this for the chest as well. They did 3 prospective studies, and their goal was to find reasons to not do a CT chest. So this is not when we should do it, this is when can we safely not do the CT chest. Or chest radiographs. They had one rule for whether to do chest radiographs, and they had 2 rules for whether to do CT chest. And again, that depended on whether you only wanted to find the major injuries or whether you want to find all injuries. Very important, this is in an awake patient that is not intubated and is hemodynamically stable and only with blunt trauma. So this is the algorithm, and I will blow it up a little bit more. As you can see, it starts with the patient, but very importantly with the physician who believes that the patient needs some kind of imaging. And then you start with a chest radiograph, and you apply these criteria. So is the patient over 60? Has there been a mechanism of rapid deceleration? Is there chest pain, intoxication, distracting injury, chest wall tenderness, or an issue with their alertness? If none of these are present, you can safely omit imaging. If one of these is present, you continue with the chest radiograph. And then you go further down in the flow diagram. You do the chest radiograph, and then you see whether it's normal or not. And then there's still some decision trees. And then you apply the nexus major criteria if you only want to find the major injuries, or you do the CT all criteria if you want to find all injuries. So reading all this, I think it's safe to not do CT if you want to be more selective. In a patient with blunt trauma that's not too old, so say 55 as cutoff, but that's very arbitrary, awake and alert, not intoxicated, no clinical suspicion, no distracting injuries, normal lab tests, and no abnormalities on your conventional workup in the trauma bay. So at least we have gotten to some sort of conclusion about when not to do imaging, or depending on your setting. So maybe we can look at the other 2 questions that I still had. Whether you do selective or immediate whole body CT will very likely depend on the mechanism of injury, the vital parameters, and the clinical signs. I think if there's any of these 3 that are questionable in your trauma bay, it's probably better to do immediate CT, and of course the state of consciousness. There's been a group that devised even a trauma injury score that you could actually use in the trauma bay, and I'm mentioning it here, but it has not been validated. I actually looked at the literature again because this was a bit a few years ago that I put these slides together, but I couldn't find a validation even now yet for this trauma score. So it's something that you will have after you get the slides, but it's not been validated yet. So some more recent publications, and I will just go through them. I don't know, Anna, if I'm doing okay for time, but The conclusions in these more recent ones are very similar, and sometimes actually disputing even between the same groups. And I want to get to so these will be in your slides. I want to get to a case from Sunnybrook, transferred in from an outside hospital. The x-rays and FAST were negative, but it was an agitated patient and hemodynamically stable. They were still transferred to Sunnybrook because of the trauma mechanism and agitation actually requiring intubation. And then the routine workup at Sunnybrook again was negative, but then all of a sudden they became hemodynamically unstable. And I'll show you the liver only. And then the coronal slides, and there's massive liver injury with active contrast extravasation into the peritoneum. And this patient needed to be treated urgently. So I put that there to just rejig the thinking again after a long talk with a lot of white slides and text, but we are radiologists, so we like to see images. In February of this year, there was actually another meta-analysis done with newer data, and what they conclude is that in patients with serious injuries from trauma, whether they're hemodynamically stable or not, whole body CT should be done, and that is probably what you are doing. And then there was a slightly more well, not old, but at least a few years ago, actually a combined English and Spanish publication on that you actually can do whole body CT also in hemodynamically challenged patients, which is not happening in all centers. They go to OR in many centers. They did a study on that. So then the last thing to sort of state is the guidelines, and these are from 2018, but they still apply. So the American College of Surgeons has a quality program for trauma, and they came up with best practice guidelines in imaging, and I think those are important. And they're important because the trauma surgeons collaborated with radiologists to come to these guidelines. And I'm highlighting one of my good friends, one of the past presidents of the ACER and a brilliant educator, but he was involved as the lead. But there were more radiologists involved in this as well. This is a very big document with 116 pages. There's 22 chapters of imaging and trauma, 5 pages with whole body CT. And they do mention the contradiction between the meta-analyses and what the REACT-2 trial did. So I will actually I will leave this with you to read, but this is some of their guidance, but I wanted to highlight the key points from there. So whole body CT allows for immediate imaging of multiple body regions. It accurately identifies the injuries, even if those are not always evident on physical examination. Generally, the non-enhanced CT head and C-spine are done, followed by the contrast enhanced. And they state the time gain, and there is a similar cost of radiation and cost to segmented approach. Very importantly, in that guideline, they say the critical importance and ultimate impact of real-time collaborative availability of interpreting radiologists in severely injured patients cannot be overstated. So being in your trauma team is very important. So in summary, and I already forecasted that when I started the presentation, I may leave you with more questions, and that's because practice is very variable and the research is very variable, so it's not all that easy to come to consensus. But I think we all understand that the more severely injured patients should get whole body CT, and you can be more selective in the lesser injured patients. So again, I started with, hopefully you judge by the questions I asked in this presentation rather than by the answers I provided. And life is a difficult balance, so the same is for the trauma patient. And I want to thank you for all being here and listening to me, and for Anna to invite me to give this lecture here. Thank you very much. Sorry for that.
Muchísimas gracias. Thank you very much. Bueno, no sé si hay alguna pregunta, algún comentario por parte de alguien. ¿Nadie? Los compañeros de urgencia se fueron también. Bueno, pues como veis, pues es un tema no es fácil y es verdad que bueno, con esto nos encontramos también aquí. Sin duda algo muy importante es el triaje de estos pacientes, o sea, la decisión la toma el trauma team según llegan a la puerta y bueno, la decisión sobre todo en pacientes jóvenes, ¿no?, que es donde más nos preocupa la radiación. Si estos pacientes, es verdad que con un TAC de total body, pues se ve cualquier, ¿no?, mínima fractura, etcétera. Realmente eso es importante para el pronóstico de los pacientes, o uno puede pasar adelante con 3 fracturas costales, igual que... Entonces, esto es un poco lo que nosotros introdujimos el protocolo de politrauma y esa yo creo que es digamos, el caballo de batalla quizá, ¿no?, el mecanismo traumático y la elección del paciente para la decisión del protocolo. También creo que es importante, como ha explicado Ferko, disponer de varios protocolos si es que vamos a hacer el protocolo de Whole Body CT. Hay algunos con menor radiación, como por ejemplo la inyección de doble contraste, que con una única adquisición, una hélice de adquisición, que reduce bastante también la radiación, y el levantar brazos, como habéis podido ver. O sea que también os animo, y a todos los residentes, ¿no?, cuando viene un paciente así, entrar en la sala del TAC, ver cómo viene, hablar con los médicos de urgencias, ver exactamente qué protocolo vamos a realizar. Y nada, pues muchas gracias a todos por estar aquí. Si no hay ningún comentario más, y por supuesto a Ferko otra vez por haber querido estar aquí con todos nosotros y contarnos, bueno, pues su experiencia y cuál es la evidencia que hay, ¿no?, ahora mismo, que como veis, pues todavía queda, no hay todavía un patrón oro que seguir en el trauma. Bueno, muchas gracias.